After having understood the basics of the chemical environment of the bloodstream, let us move on to ABGs, the most commonly used tool to measure acid-base imbalance that helps guide treatment designed to restore pH balance and effective oxygenation. Blood gas analysis is usually based on sampling of arterial blood, mixed venous blood sampling from a pulmonary artery catheter, SVO2, and central venous sampling from a central line, SCVO2, may also be performed in the ICU. A systemic analysis is critical to the accurate interpretation of ABG values to determine the origin of acid-base imbalance and level of compensation. Step 1. Check the pH. When there is a perfect balance of acid and buffer, the pH is termed neutral or perfect. If it is abnormal, identify whether it is on the acidotic side, less than 7.35, or alkalotic, greater than 7.45 side of the normal. Step 2. Check the PaCO2. This is a measure of partial pressure that the dissolved carbon dioxide exerts in the arterial blood. Check PaCO2 for perfect levels, 40 millimeters of mercury. If not, determine if the direction is above or below 40 millimeters of mercury. Identify whether it is on the acidotic side, greater than 45 millimeters of mercury, or alkalotic, less than 35 millimeters of mercury. Elevated carbon dioxide lowers the pH, while decreased carbon dioxide increases the pH. Using this technique helps determine whether the primary problem is respiratory, involving PaCO2, or metabolic, reflected by bicarbonate. Check bicarbonate and base for perfect levels. Serum bicarbonate is one of the major components of acid-base regulation by the kidney. Bicarbonate is excreted by normally functioning kidneys in direct proportion to the amount of circulating acid to maintain acid-base balance. Having said this, I would like to mention here that serum bicarbonate is affected by both respiratory and metabolic components of the acid-base system. The relationship between metabolic acidosis is not particularly predictable. To determine the cause of bicarbonate changes as the source of a pH problem versus compensation, the relationship to pH must be evaluated. Base access or base deficit uses a calculation to reflect the presence or absence of buffers. The calculation reflects the tissue and renal tubular presence or absence of acid. As the proportion of acid rises, the relative amount of base decreases. And as the proportion of acid decreases, the relative amount of base increases. Abnormally high values greater than +2 reflects alkalosis or an excess of base, whereas low values less than -2 reflect acidosis or a deficit of base. Therefore, using this technique helps determine whether the primary problem is respiratory, involving PaCO2, or metabolic, involving bicarbonate, or both. Correlating the direction of pH change with the direction of change in PaCO2 and hydrogen ions, the bicarbonate, is essential. Assess pH for acidosis or alkalosis and then evaluate whether the change in carbon dioxide or hydrogen ions, bicarbonate, is most reflective of the direction of the pH change. Normal range of SaO2 is 95% to 100%. The partial pressure of oxygen, or PaO2, is a measure of dissolved oxygen in the arteries. Normal range of PaO2 is 80 to 100 millimeters of mercury. SaO2, or oxygen saturation, reflects the loading of oxygen onto hemoglobin in the lungs. Hemoglobin is the primary transporter of oxygen. Oxygen must be released from the hemoglobin, dissolve in blood, and excrete pressure to diffuse across the cell wall. So we check PaO2 and oxygen saturation to determine whether they are decreased, normal, or increased. Decreased PaO2 and O2 sat may signal the need for increased concentration of oxygen or alveolar recruitment strategies. High PaO2 may indicate the need to decrease delivered oxygen concentration. Oxygen evaluation is the same for all arterial blood gases, period. With this basic information, let's move on to talk about different types of acid-base imbalance. Respiratory acidosis. Let's take an example. pH of 7.28, PaCO2 of 55, bicarb 24, PaO2 at 92, SATs are 91%. So let's start. pH of 7.28. It's on the acidotic side. Question 2 is, where is the acid being generated? Respiratory or metabolic? Look at the next level. PaCO2 is 55. Respiratory acid is accumulating. Bicarb is 24. It's perfect. Metabolic acid is not present. Let's investigate further. Elevated PaCO2 or hypercapnia signals alveolar hypoventilation. It's always related to a ventilation problem caused by inadequate therapeutic interventions or lung pathophysiology resulting in retention of PaCO2. So the problem is respiratory acidosis. It can occur when there is airway obstruction, loss of alveolar recoil, or inadequate time for exhalation, affecting the ability to express carbon in the environment. Is there compensation for the respiratory acidosis? Only carbon dioxide is elevated. Bicarb is normal. So patient has acute respiratory failure causing an accumulation of carbon dioxide. There is no compensation at this time. Next step, check PaO2 and SATs. PaO2 is 92. Not perfect, but within normal range. SATs 91%, definitely not perfect. So what is the first step? Use of oxygen. Use a device that delivers oxygen to correct the alveolar levels of oxygen. Evaluate the risk for poor tissue oxygenation. ABG readings help evaluate ventilation, but both ventilation and perfusion must be evaluated as part of oxygen delivery to the cell level. Changes in heart rate, blood pressure, respiratory rate, urine output, SpO2, ScVO2, and serum creatinine are all indicators of poor tissue oxygenation. If PaCO2 is greater than 50 to 60 millimeters of mercury, there may be a need to intubate and place the patient on mechanical ventilation. Primary mechanism to treat respiratory acidosis is to increase the tidal volume and or the respiratory rate to increase the minute ventilation. Next step, normalize the pH. Although a life-threatening pH must be corrected to an acceptable level promptly, a normal pH is not the immediate goal. Use of bicarbonate is generally avoided because of the risk of alkalosis when the respiratory disturbance has been corrected. Now evaluate the compensation. Compensation occurs in the presence of normal renal function, though the kidney's response to an abnormal pH level is very slow, takes anywhere from 4 to 48 hours. Kidneys are able to facilitate a near normal pH level by excreting large quantities of hydrogen ion from the body. Increase in carbon dioxide increases the carbonic acid and therefore the pH decreases. The increased carbonic acid is presented to the kidney where the hydrogen ion is separated from the bond, yielding bicarbonate. This free bicarbonate provides additional buffer. In addition, the kidneys excrete the free hydrogen ions in the urine to reduce the acid level. There's one more thing happening. To compensate for the acidosis created by the increased carbon dioxide, potassium ions are released from cellular proteins and hydrogen ions take their place and bound to the proteins. The result is serum hyperkalemia, reflective of intracellular hypokalemia. So our original problem was a pH of 7.28, carbon dioxide of 55, PaO2 of 92, and SATs of 91%. With a functional kidney and compensation over time, if ventilation is not effectively managed, the bicarbonate will increase to 32, which will correct the pH to 7.35, still on the acid side, but in normal range. Carbon dioxide remains at 55. Oxygen at 4 liters nasal cannula increases the PaO2 and SATs to 100%. Therefore, restoring effective alveolar ventilation remains the main goal of respiratory acidosis. Respiratory alkalosis. Let's take an example. Patient comes with a pH of 7.48, PaCO2 of 30, bicarb 23, and base access +1. So let's start the analysis. Step 1. Look at the pH. pH is greater than 7.40 on the alkaline side. Step 2. Look at the PaCO2. It is decreased to 30, reflecting hypocapnia. This signals alveolar hyperventilation, decreased respiratory acid causing an alkaline state. Step 3. Look at the bicarb. It's 23, which is less than perfect but still in the normal range. It must be determined here if there is a metabolic contribution to the alkalosis or if there is compensation provided by the kidney. Look at the base axis. It is +1 within normal range. So what are we looking at? PaCO2 is low, pH is high, bicarb is normal, patient is exhibiting a rapid respiratory rate with deep breaths. SpO2 may be normal as the patient is breathing very rapidly but effectively. However, when the respiratory rate is very rapid, there is less time for oxygen diffusion, so it is possible that the patient's oxygen levels may decrease. Respiratory alkalosis occurs as a result of an increase in the minute ventilation. Acute alveolar hyperventilation results most frequently from anxiety and is therefore commonly referred to as hyperventilation syndrome. Having said that, caution must be applied to evaluate whether hyperventilation is actually a compensatory mechanism for primary metabolic acidosis. In the absence of metabolic acidosis, help the patient alleviate anxiety, encourage slow deep breaths, administer sedatives or tranquilizers as prescribed. Kidneys excrete bicarbonate and retain additional hydrogen ions for the lack of carbon dioxide, the respiratory acid, within 4 to 48 hours. Also, in the alkalotic environment, cells release hydrogen ions and take up potassium. The result is serum hypokalemia with intracellular hyperkalemia. So our original problem of a pH 7.48 with a PaCO2 of 30 with compensation over time, the kidneys bring down the pH to 7.44 by excreting bicarbonate. So the bicarbonate drops to 19. If there is only one problem contributing to the pH abnormality, removal of acid by the respiratory system should be compensated by acid retention by the renal system. Metabolic acidosis. Let's take an example. Patient comes with a pH of 7.28, PaCO2 of 39, bicarb 16, PaO2 98, SATs 99%, base access -6. So let's start analyzing. Step 1, look at the pH. pH is not perfect, it is on the acid side. So definitely there is increased acid production. Question is which one, respiratory or metabolic? Look at the PaCO2, it's 39, slightly decreased but within normal range. So the cause of acidosis is the metabolic acids. There can be many reasons for metabolic acidosis. Excessive lactate and ketones can cause acidosis and contribute more unmeasured positive hydrogen ions into the circulation. Decreased renal tubular function or chronic renal failure, if the kidney is unable to excrete hydrogen ions or if the load is beyond tubular transport capabilities, an increase in hydrogen ion occurs. Bicarbonate decreases as the kidney has lost the capability to regulate and create appropriate bicarbonate. So the conjugation of hydrogen ions and available bicarbonate yields an increase in carbonic acid. As carbonic acid increases, pH goes down. Also, ingestion of exogenous acids, aspirin, methanol, alcohol, can all cause a wide anion gap. Step 2, look at the PaCO2. It's 39, slightly decreased but within normal range. That means the lungs are not retaining carbon dioxide and are not exhaling excessive amounts of carbon dioxide. Step 3, look at the bicarbonate. Bicarbonate is 16, base excess is -6, both below normal range. This means the metabolic acid, the hydrogen ion, is increased. Like mentioned earlier, reason could be any combination: acute or chronic renal failure, cellular production of acid, lactic acidosis or ketosis, or ingestion of acids like aspirin and methanol. Having said this, it must be determined if acidosis is the primary problem or a compensatory mechanism for metabolic alkalosis. PCO2 is normal while bicarbonate is decreased. Patient is exhibiting a normal respiratory rate with normal depths. With the decreased bicarbonate but normal PCO2, patient is not compensating for respiratory alkalosis. So the decreased bicarbonate is the primary problem, and no compensation is apparent by the lungs. The PaO2 and SaO2 are normal. Patient is breathing normally. Patient has normal oxygenation. So we do a step 6, which is performed only in metabolic acidosis. We evaluate glucose, ketones, lactate, and tissue oxygenation sometimes if necessary. Again, check for the reasons mentioned earlier. Is it a kidney problem? Check BU and creatinine. Is it a high chloride problem? If so, chloride will have to be high. Did the patient ingest acids? If the answer to these questions is no, then evaluation of glucose and ketones is necessary. ABGs are done promptly following confirmation of hyperglycemia to assess for diabetic ketoacidosis. With lactic acidosis, evaluation of tissue perfusion and oxygenation requires measurement and comparison of arterial saturation, SvO2 and ScVO2. For a lactate greater than 4, assessing perfusion and oxygen consumption at the cellular level is important. Both DKA and sepsis will be discussed at length as separate topics. Body's compensatory response to acute metabolic acidosis. When hydrogen ions, the acid increases, pH decreases in the plasma. Central respiratory center responds by increasing the rate and depth of ventilation to exhale carbon dioxide and returning the carbonic acid, therefore the pH to normal, but never to perfect levels. In addition, if kidney is functional, acid will be excreted and bicarbonate reabsorbed. So the original problem of pH 7.28, PaCO2 of 39, bicarb at 16, the lungs compensated by separating the carbonic acid into carbon dioxide and water, and with the help of the respiratory center, exhale the carbon dioxide. The bicarbonate remains at 16, which means the metabolic acid, the hydrogen ion, is increased. Here is the cause of the problem that decreased the bicarbonate. So we will talk about collaborative management of acute metabolic acidosis in the next slide. It is important to treat the underlying disorder: diabetic ketoacidosis, alcoholism-related ketoacidosis, diarrhea, acute renal failure, renal tubular acidosis, poisoning and drug toxicity, or lactic acidosis. They all need to be treated, and that remains the first step in managing acute metabolic acidosis. Anion gap is used to determine if metabolic acidosis is due to an accumulation of non-volatile acids such as lactic acid or keto acids. Both contribute a positive charge due to an excess of hydrogen ions or from net loss of bicarbonate. Treat the pH only if the patient's life is threatened by the pH. Sodium bicarbonate may be indicated when arterial pH is less than 7.15. Serum hyperkalemia is present, but there is an intracellular potassium deficit. If potassium deficit exists, potassium less than 3.5, it must be corrected before sodium bicarb is administered, because when acidosis is corrected, potassium will shift back to the intracellular spaces. This shift in potassium could result in serum hypokalemia with serious consequences such as cardiac irritability and fatal dysrhythmias. Mechanical ventilation may be required on the basis of ABG results and clinical signs. Respiratory rate and tidal volume on the vent should be large enough to maintain compensatory hyperventilation until the underlying acidosis is resolved. Metabolic alkalosis. So let's take an example. Patient with the pH of 7.58, PaCO2 of 40, bicarb 35, SATs 99, PaO2 of 99. Now let's start analyzing. Step 1, pH is not perfect. It's on the alkaline side. Step 2, PaCO2 is 40, which is perfect. Step 3, bicarbonate has increased to 35, indicating the kidneys are retaining bicarbonate. Most commonly, it reflects excessive loss of hydrogen ions, loss of gastric acid from vomiting or gastric suctioning or diuretic therapy. Excessive reabsorption of bicarbonate, when it happens post-hypercapnic alkalosis, which occurs when chronic carbon dioxide retention is corrected rapidly. Or it could be ingestion of alkaline, excessive bicarbonate administration, that is overcorrection of a metabolic acidosis or ingestion of over-the-counter antacids. Here is the cause of the problem, acute metabolic alkalosis. Bicarbonate is 35, which means the metabolic acid and hydrogen ion is decreased. Step 4, the PaCO2 has not increased. The patient is exhibiting a normal respiratory rate with normal depth. With an increased bicarbonate and normal PaCO2, the patient is not compensating for a metabolic alkalosis. Step 5, the PaO2 and SATs are normal as the patient is breathing normally. The patient has a normal oxygenation. Body's compensatory response to metabolic alkalosis. When hydrogen ions, when the acid decreases, pH increases. The central respiratory center in the brain responds by decreasing the rate and depth of ventilation to 50 to 75% of the normal level. This method of compensation is very poorly tolerated as patients will almost stop breathing. So the original problem of pH of 7.58, PaCO2 of 40 and bicarb of 35, with compensation the pH goes down to 7.45. The PaCO2 has increased response to an increased bicarbonate level. When bicarbonate increases, the pH goes up, indicating less hydrogen ion is present in the body. The pH normalized on the alkaline side, so the patient has fully compensated metabolic alkalosis. Management of acute metabolic alkalosis. Managing chloride deficit. Normal saline infusion may correct volume and chloride deficit in patients with gastric alkalosis because of gastric losses. Metabolic alkalosis is difficult to correct if hypovolemia and chloride deficit are not corrected. Correct hypokalemia. KCl is indicated for patients with low potassium levels. KCl is preferred over other potassium salts because chloride losses can be replaced simultaneously. Sodium and potassium chloride, effective for post-hypercapnic alkalosis, which occurs when chronic carbon dioxide retention is corrected rapidly. If adequate amounts of chloride and potassium are not available, renal excretion of excess bicarbonate is impaired and metabolic alkalosis continues. IV administration of isotonic hydrochloride, ammonium chloride, or arginine hydrochloride may be warranted if severe metabolic alkalosis, pH greater than 7.6 and bicarbonate greater than 40 to 45 exists, especially if chloride or potassium salts are contraindicated. This covers acid-base imbalances. Next, we will talk about intubation, mechanical ventilation, and the different modes of ventilation. Thank you for watching and see you soon.